today for our presentation on infection prevention. My name is Anna Neese, and we will be talking about CAUTIs today, catheter-associated urinary tract infections. Today's objectives are to summarize CAUTI and how measured, discuss the current plan for remediation in the organization, identify the financial impact of the quality issue, review a variety of positions, suggest a couple of new recommendations for remediation, discuss the current response to interventions and how to improve, and identify some risks to utilization. CAUTIs are truly a quality issue. When we look at our goal being 0, when we look at our data for the past year from the second quarter of 2016 all the way through midway through the first quarter of 2017, we see we're not making significant headway. We are still having anywhere between 10 to 16 CAUTIs per quarter, and we're on the same track for 2017, halfway through having 6. The prevalence of the issues shows us that UTIs are in the top 5 for healthcare-associated infections. 70 to 80% of all UTIs are caused by indwelling catheters, with a higher incidence in women. We've seen that 1 in 3 women will be diagnosed with a diagnosis of urinary tract infections by age 24, and the longer these catheters are in place, the higher the risk of infection. Our current practices at our hospital have a nurse-driven protocol and catheter review daily to make sure indwelling catheters are removed as soon as possible. We have evaluated products to make sure they're closed systems. We have consistent pericare, annual competency checkoffs that begin at onboarding and annually at skills fair. We've encouraged the utilization of the bladder scanner with education. We've done more education on catheter care and maintenance of catheters, as well as instituted a buddy system for catheter insertion that's a 2-person system to ensure sterility and make sure that the process is done correctly. The financial impact of CAUTIs can be significant. The rewards or penalties from the 2010 Affordable Care Act penalty or payments affect 2% of Medicare payments and equal about $2 billion for hospitals annually within the United States. Since CAUTIs constitute costs that are significant to the health service, infection prevention is very important. Longer hospitalizations increase the cost. Treatment for the infections themselves, from the antibiotics to the longer time that the patients are in the hospital, long-term medical conditions that may be impacted in regards to the infections, any resistance to antibiotics. It's estimated that 17 to 69% of CAUTIs could have been prevented, totaling 380,000 infections, 9,000 related deaths to CAUTIs per year. Pretty significant financial impact and impact to our community. The Joint Commission has been involved since 2005 in our fight against CAUTIs. They've developed uniform standardized technical specifications for measurements. They've tested care measures on quality. They've made recommendations for performance. And in 2017, the National Patient Safety Goals on CAUTI prevention were published. They've been a fantastic resource. The Institute of Medicine is a nonprofit organization that provides evidence-based research and recommendations for public health and science policies. It has a dedicated section for urinary tract infections in adults with answers to many questions, including risk factors, signs and symptoms, prevention, and treatment recommendations. It's a fantastic section that asks questions with answers, like what is the most common cause of urinary tract infections? What is the most common urinary tract infection risk factor in adults? And what are the signs and symptoms of UTIs in adults, for example? Lots of great information from this website and huge amounts of support with evidence-based practice and recommendations. The Agency for Healthcare Research and Quality is very supportive of reducing these types of infections. They're participating in the National Stop CAUTI project that aims to reduce the mean rates of CAUTIs in the United States by 25%. The initiative is participating with Association for Professionals in Infection Control and Epidemiology, state organizations, and more than 900 hospitals in a varied 41 states across the country to institute the protocols for CAUTI reduction practices. When you visit the Agency for Healthcare Research and Quality website, you can find great resources under the topic of catheters that can assist in reducing the rates of CAUTIs. They also give you a link to the toolkit for reducing CAUTIs in hospital units. That's an implementation guide. It's a fantastic website with lots of great information. The Veterans Health Administration is nationally and internationally known for its commitment to innovative quality and safety programs and for its transparency and being accountable for the results achieved by those programs. The Veterans Health Administration issued its first comprehensive facility-level report of quality and safety data, reporting on care provided in inpatient and outpatient settings, quality of care within specific patient populations, and patient satisfaction and outcomes in 2008. Raw data from both reports are published on data.gov to allow veterans and the public to track changes, improvements in care, and the results of initiatives to address issues noted in previous reports. Further information may be found at hospitalcompare.hhs.gov. Part of the 2013 Hospital Quality Report Card that's on their website does have an entire section on nosocomial infections. So you can see that hospital-acquired infections are a priority for the Veterans Health Administration as well. Now I ask you to consider something as we move forward. We've already talked about all the recommendations and the things that we've done in our hospital to try to improve the rate of CAUTIs. Well, currently we're not where we need to be. We're not at a rate of 0, and I think we need to look outside the box and move a little bit further into what we can do to prevent these. I think we need to implement 2 more recommendations, and these are evidence-based recommendations that you can find online through research, through journals, everywhere. The first thing is that I think that we need to stop inserting indwelling catheters. I think that the longer a catheter is in place, the higher the risk is for these CAUTIs. Most of these that we're seeing are in our intensive care units or are in patients that have had for long term over the 48-hour time period. So looking at only using in and out cathing only, as well as using external device usage if we have to connect something for intake and output documentation. Adding these 2 recommendations, I think maybe we can get our rate down to 0. One of my recommendations is an in and out temporary catheterization. Single-use catheters for men and women inserted to drain urine from the bladder and then removed. Use with collection bag as a closed system or use without the bag, avoiding indwelling catheters at all cost. Let's get serious about no indwelling catheters to be used. We know that indwelling catheters are the leading cause of CAUTIs. We know we need to get away from them. Daily observations haven't worked. We've tried everything. Let's do something different. Let's try these other types of catheters for those types of patients that cannot do in and out catheters. One is an example for women of a PureWick that is being used at other hospitals in our area on a trial basis to see. It's a flexible contoured external catheter. It's like a wick. It's positioned against the area where the urine exits the body. It has a slight vacuum that is not felt by the patient. It pulls urine through the wick even during the full speed urinations. The urine continues quickly through vinyl tubing until it reaches a storage bag that's away from the patient's body. This is the way to go, I think, for women when we don't want to go with that indwelling catheter. They have been our biggest challenge for many years over this. For males, let's go back to the condom catheters that we used. These will allow no skin breakdown. They will keep the urine away from the skin. There's nothing indwelling about them that can cause infection. The one thing that's important with both of these catheters is going to be peri-care on a regular basis for these patients and making sure that everything is in the correct position. You know, teams may face many risks as we step outside the box and move forward with new initiatives. But I think as leaders, we need to encourage these risks and we need to evaluate the progress. There are several fears that the team may face or several issues. One is the fear of retaliation or rejection, of somebody saying we're doing something that's not right or rejecting our proposition altogether. There may be an increased risk of some unforeseen hazards. When you've never used a product before, you've never set a protocol in place, things may happen that we didn't expect to happen, and that may cause stress to the team, or it may cause us to fail or not be as successful as we want to be. The risk of loss of net income. I don't think in any way by initiating something that we think may help our community, I don't think that's going to cause us to lose our jobs, but there may be some reimbursement, or there may be some infections or things that do occur that we did not expect. There may be skin breakdown for a patient that we didn't expect by using one of these. And those are some things that we need to look at, the cost, and if we are exceeding where we currently are. The fear of making a mistake is always an issue as a team gets together and makes decisions. But if you are in a fear of making a mistake, then you will never make any decisions outside what you already know is right. Accepting the unanticipated outcomes, whether or not they're positive or negative. These are how we learn and how we grow, and this is how research brings us the evidence-based practice. We have to learn from all of the things that are negative and positive, and continue the positive and alter the negative to be good. There's a fear of a quality issue getting worse instead of better. What if our data collection shows us that we've got more CAUTIs than we had before? There's a fear of that, and there's a risk. But I think it's time that we tried something new, since our current things are not working as we had hoped. Vulnerability, risk-taking, stretching, they're all required for many reasons as leaders. First, the things that we're dealing with now are very different from the things that people were dealing with in the past. Skills that'll be needed in the coming age, they're very different from those that we needed in the industrial age before. Past practice of bureaucratic command and control could not be assumed to be effective in the new environment in which the distribution of knowledge has been radically altered, and the skills that are needed to manage the environment are underdeveloped. The leaders of the healthcare profession need to maintain a focus on creating a framework for each profession, a framework that allows them to understand and manage the future rather than sustain the past. Coaching employees to be comfortable with risk-taking, being vulnerable, and stretching the boundaries of current thinking and practices is really critical for the nurse leader in today's time. Personal authenticity is very, very important. Being an authentic leader. The values of a leader that are authentic are shaped by personal beliefs, and they're developed through study, reflection, and dialogue with others. The values create a moral compass for the leader and provide guidance in determining the right things to do, rather than blindly attempting to take on a style of someone else. Accept personal faults as well as strengths, and avoid attempting to win approval of others by covering up shortcomings and sacrificing. You don't want to sacrifice authenticity to gain the respect of anyone. Integrity is what it's about as a leader. Making sure that everything that you do, it's essential for building trust. It requires behaviors that reflect caring about others and their own success. Maintain a focus on creating a new framework for each profession, and making sure that, people that work with you or that work for you, they trust you and they value your leadership. That's how we can mitigate the risks for our nurses. Errors are going to happen. As nurse leaders, how we handle those, we need to handle them as opportunities for improvement. If people see that we're upset by errors or that they impact us significantly, they're going to be upset about them. So we need to acknowledge that remorse or that failure that the person feels. We need to talk with them, seek clarification from that person, and provide the support that they need so that they don't feel so bad about the error that had been made. We need to attempt to discover the sources of the problem, what caused it to fail, or how did the error occur. Take action to prevent future repetitions of that area, and create or strengthen support structures we have in place so that we know that is not going to happen again, and that we know how to fix it. One strategy for handling errors is really honoring excellence. Trial and error nature is the nature of healthcare. It's the evolution of best practices. It's continual improvement processes. It's the nature of human human interactions, and it's a positive culture of excellence. It's about trial and error to find what works and move forward with that, finding out what doesn't work and why to fix it. These are how we make improvements and how we move forward in healthcare. Monitoring for improvement and changes is critical. We use quality indicators, quality improvement processes, quality management teams all get involved. Leaders can redesign the future to support the practices that minimize system breakdowns and individual mistakes through understanding the errors of the past. We have to continue to monitor things the way we're monitoring them now to make sure that processes that we put in place improve things, and if they don't, that we take action to fix them. We also need to look at documentation of errors so that we can determine what the causes were, so that we can then put plans in place to fix those so they don't occur again. Actions tend to become routinized, which makes detecting and solving ethical problems difficult. Action is typically socially governed, which makes the allocation of responsibility more difficult and raises the question of whether it's good or bad power that's exercised in each case. Actions often guided by decision-making strategies which involve a risk of bias. We have a tendency to use certain kinds of psychological mechanisms to excuse ourselves from ethical behavior. More or less irrelevant situation factors such as finding a dime greatly influence ethical conduct, and the vast multitude of ethical intuitions, theories, and values makes it difficult to find unanimous ethical answers. Thank you all for your participation in today's presentation on CAUTI. I very much appreciate it.